Good morning, one and all. Today we'll be talking about the adjunct, which is the most important adjunct in a dental physician's routine practice, that is the intraoral radiographs. The various spectra of radiographs which have to be taken by a dental physician and which is one of the most important adjuncts and the helping tools in dealing with the patient on a routine basis. So we'll be talking about the intraoral radiographic projections, the different kind of projections which are used by the dental physician on a routine base at a chair side. We won't be talking about the higher end radiographic techniques. We'll be talking about those which will be used at the chairside investigations to help the patient, to help the dental physician in reaching his goal. We'll also be talking about what is normal and what is abnormal, that we can get to know only by knowing the normal anatomical landmarks, radiographic anatomical landmarks on the various radiographs which we take. So moving over to the subject per se. First, the definition of intraoral radiography. The intraoral radiography clearly tells us this is any technique which can use small dental films placed in the mouth to obtain an image of the local areas. That is to say, the tooth per se and the anatomical structures which surround it. That is to say, the alveolar bone, the alveolar margins, the supporting bone, and the tooth per se. So this is nothing but a localized visualization. That is to say, a specific tooth per se. So using these small radiographs which are placed inside your oral cavity and then taken. So basically these can be classified depending upon the type of radiograph which we use and the situation wherein we use, and for what purpose are we using this particular radiograph. We can broadly differentiate them into three types. First is the intraoral periapical projections. The second one is the bite wing, and the third one is the occlusal projections. The first one, as your name suggests, this is limited to the periapical region. That is to say, if a dental physician needs to know the information or the periapex of that particular tooth, of one specific tooth, then we use this particular radiographic projection to obtain information of that particular tooth and its surrounding structures, with or without helping information from the surrounding teeth. So the next one is a bite wing. The name suggests it is a bite wing kind of projection. So is to say, when the person bites, the occlusal tables which connect to each other in the maxillary and the mandibular projection teeth, and these particular bite wings are limited to the coronal and the middle third of portion, which do not give any information about the periapex. We'll be talking about how we take these projections and where we can use these particular projections to the dental physician's advantage. The third one, the name suggests occlusal. So the whole occlusal table of a particular arch, say the maxillary or the mandibular, the whole arch is taken into consideration and the surrounding structures are taken into consideration. Different angulations will give different views or give different aspects of a particular occlusal arch, that being the occlusal projection. So what is periapical radiography? Now this is defined as an intraoral technique which is designed to show the individual teeth and the tissues around the apices. Now the word apices is the most important over here because this is where the utility of this particular radiograph comes into play, that is the periapex region. You know, the most common kind of infections or most common kind of problems with the patient presents to the dental physician as something which is related to the periapical region, be it the common caries or be it the common sequelae of caries. The periapex of the particular tooth plays an important role, and the radiograph or the investigative procedures which can give out information of this particular periapex is the most important aspect for a dental physician. So as you can see in the sample radiograph, we see the typical molar kind of a periapical projection, wherein it gives information about the specific molar, its periapical region, the structures surrounding it, that is to say the alveolar bone, the pedial space, or the root apex, or the surrounding bone, and the surrounding bone which takes into consideration the adjacent teeth also. So this is limited to that particular tooth, and it is small radiograph. This being the periapical radiograph, and as I told, the indications or the uses of this particular radiograph are limited to only one particular teeth and its periapex. So what are different techniques? Now there are two different techniques. One is the paneling technique, and another is a bisecting angle technique, which are most commonly used in the dental setup. Both these techniques have their own advantages and their own disadvantages, and depending upon the purpose for which we are taking the radiograph, we have to strike a balance between the advantages and the disadvantages, and then choose a particular technique. So if we move over to the paneling technique, it is also called as long cone technique or right angle technique. Now, why the names long cone or right angle? Predominantly because of the cone length which is used in this particular technique. It is a longer cone. We have two types of cone. One is short cone and a long cone, which is used in for intraoral periapical radiographies. Now, what we use over here is a long cone technique. That is to say, a long cone gives specific characteristics to the X-ray beam, which is helpful in taking this particular radiograph. Now, as the name suggests, it is a paralleling technique. That is to say, when the X-rays are produced from the anode, they are produced at different angulations, at different speeds. Now, barring the initial prohibitory limitations which we have, the filtration or the collimation, all these particular equipments or the parts of the X-ray tube help the X-ray beam to attain a stable angulation, that is to say a parallel angulation, which can produce non-distorted, undistorted geometric representations of the teeth which we take in. Now, even though we use the collimators to produce a parallel beam, there's still few slight angulations or slight difference in the angulations between the individual X-ray beams if we take them as consider them as lines. Now, what this long cone technique does is the long cone basically enables the perfectly parallel rays to exit from the cone of the X-ray machine, and the slightly different angulations which they might be there for the with respect to the other X-ray beams are totally absorbed by this long cone. So basically what we are trying to do is we are more trying to streamline the X-ray beams so as to attain a perfectly parallel X-ray beam which hits the specific tooth of interest at right angles. Now, we all know when a particular image has to be cast onto a screen, if the rays are parallel to the specific tooth of interest and the receptors, we get an exact replica of that particular tooth or area of interest. Now, if the X-ray beam strikes the tooth at an angle, there might be foreshortening or there might be elongation, primarily owing to the fact that the X-ray beams are not perpendicular to the tooth of interest. So, because of this long cone technique, and this enables the X-ray beams to hit the teeth specific area of interest at right angles, thereby it minimizes the geometric distortion and increases the sharpness. So, as I was saying, because of this long cones, we enable the X-ray beams to attain a particular parallel structure. More parallelism is obtained because of the long cone, and this enables the X-ray beams to hit the specific area of interest at right angles, thereby minimizing the geometric distortion. Also, this also enables in increasing the sharpness, primarily because it reduces the width of the penumbra region which is obtained by any X-ray beams which hits the tooth at different angulations. Now, we know the umbra is the area of the shadow which has a maximum sharpness, and the penumbra is the area surrounding the umbra which gives rise to the blurring nature of the shadow. Now, this blurring can be reduced by reducing the angulations, by reducing the X-ray beams hitting the area of interest at different angulations. So, this being the main advantages of paneling technique. Now, the other advantage over here is the usage of film holding instruments. Now, we all know to obtain this paralleling nature or the parallel beam of the X-ray beams, both the tooth, the X-ray film as well as the source need to be parallel to each other. So, as to say that if we place the X-ray beam, X-ray receptor closer to the tooth, there is a slight difference in the angulations primarily because of the alveolar crest. But if we slightly move the X-ray receptor further away from the tooth, then we will be able to achieve the exact parallelism, owing to the fact that the shallow or the depth of the vault can be used to effect. to this effect. So the different instruments which we use over here enables us to do specifically this, that is to maintain the parallelism between the X-ray receptor and the X-ray beam as well as the tooth of interest by placing it at optimally large distances. Now this is one example. We can see the white structure is the aiming cone, wherein the X-ray cone is aimed at the specific area. The holding arm with the holders, which depending upon which kind of tooth we are taking into consideration, be it the anterior or the posterior, that kind of bite block is used wherein the patient bites onto it, and then the holders on the bite blocks holds the specific film at the further distance away from the tooth. This provides stability, this provides no arbitrary estimations of the image. It will be perfectly reproducible. That is to say, if we take the same kind of radiograph on two different people at two different points of time, because of the stability of this particular holding instrument, these results or these X-rays which are produced of that specific tooth can be reproducible. So that being the basic advantages of paneling technique. The patient position, as we all know, for the maxillary and the mandibular, it's both for the paneling as well as the bisecting angle technique is almost the same. For maxillary projections, the patient is asked to sit upright. The chair position is perpendicular. It's raised up a little so that the patient's occlusal line is parallel to the ground. So this is the first picture, shows the patient position wherein the occlusal or the alatragal line, the line passing from the ala of the nose to the tragus, that is parallel to the floor, and the patient position is upright with the chair position a little more forward. Now for the mandibular projections, because of the angulation of the occlusal plane which is downward, so we recline the patient at 45 degrees so as to bring the occlusal plane parallel or upwards to decrease the angulation and bring it parallel to the floor of the ground, and then we project the X-ray beam. So the different tooth specific positions, this being the general maxillary and the mandibular patient positioning, the cone's vertical angulation as well as the horizontal angulation as well as the central ray beam which passes or which has to pass to obtain optimum pictures or optimum X-rays of the specific teeth without compromising on the sharpness or the details or the geometric distortions. So for each particular tooth, a different angulation, be it the vertical or the horizontal angulation is given. The vertical angulation is nothing but the angulation which is made between the central ray as well as the sagittal or the occlusal plane as such. That would be the vertical angulation, and the horizontal angulation is nothing but mainly the angulation which enables the central X-ray beam to hit at perpendicular angles to the tangent which passes through the buccal surfaces of the maxillary or the mandibular teeth. So that being said, the first is the maxillary central incisor. If you see the patient positioning over here, the central ray is nothing but which passes through the contact point of both the central incisors, and of course it has to be perpendicular to the plane of the film, and again the horizontal angulation has to be 0 degrees. That is to say that if the central X-ray beam has to go perpendicular to the tangent which passes through the buccal surfaces, the horizontal angulation has to be 0 degrees. So this being the patient positioning, and this is the placement of the X-ray film inside the oral cavity. Now you can see, because of the film holding instruments, how we further away place the X-ray film further away from the lingual surfaces of the central incisors, so as to compensate for the angulation which is produced by the alveolar crest. So if you have to place it parallel to the teeth, we have to take it further away, and because of the depth of the vault of the maxillary plates, we can easily place the X-ray film parallel to the teeth. Now the point of entry from outside the extraorally, we see it is at the midline below the septum. Now the point of exit from the septum, we see it is at the midline below the septum. Now the point of entry from outside the extraorally, we see it is at the midline below the septum. Now the point of exit from the septum, we see it is at the midline below the septum. Now the point of entry from outside the extraorally, we see it is at the midline below the septum. Now similarly, for the maxillary lateral incisor, primarily because of the arch of the maxillary occlusal plane, we can see the laterals are slightly tilted towards the tilted mesially or distally, depending upon which side we are taking over. So the central ray passes arbitrarily through the middle of the lateral incisor, and the point of entry is nothing but high on the lip, which is 1 centimeter away from the midline. So this enables the central X-ray beam, which passes through extraorally, to pass through the middle of the lateral incisor, thereby hitting the specific area of interest at right angles. Now this is the placement of the film holding instrument and the X-ray film inside the oval cavity, which is almost similar, just with a slight change in the angulation, so that it is parallel to the long axis of the lateral incisor. Now the maxillary canine, the beam has to pass through the mesial contact of the canine. Now it is a standard rule wherein we say the maxillary canine, the mesial contact point has to be open. Now that is the primary issue, which is because of the angulation or the placement of the canine within the maxillary arch. It is, for most part of the times, it is not possible to open both the mesial as well as the distal contact, because it is the cornerstone of the arch. So as to say, it has a steep angulation wherein we can, for most of the times, we can have only one open contact and the other contact slightly overlaps onto the first premolar. So in those conditions, what is said is, the standard rule is to open the mesial contact only, primarily because the distal contact will be open when we take a premolar projection. So when we take a full mouth interval periapical radiographs, we have to take care that only the mesial contact is open, so as to say the beam has to be parallel to the mesial contact rather than the distal contact. Now if the canine is smaller, or if it is not exactly it doesn't have the steep angulation, in those conditions we might have both the mesial as well as the distal contacts open. The central ray, which has to pass through the canine eminence, that is the most prominent bony projection above the canine root region. Now the point of entry is nothing but the intersection between the distal and the inferior borders of the ala of the nose. If you see the picture, this intersection between the distal as well as the inferior border of the ala of the nose, that intersection point is a point of entry extraorally, so that it enables the central X-ray beam to pass through the canine eminence and hit the canine at right angles. Now the maxillary premolar central ray, again standard, it has to be perpendicular to the film, and it has to pass through the interproximal area between the first and the second premolars. Now both the first and the second premolars is taken by this maxillary premolar projection, wherein the point of contact between both the first and the second premolars has to be the area wherein the central beam hits it perpendicularly. The point of entry, again, it is below the pupil of the eye along the maxillary arch, which enables it to pass perpendicularly to the through the point of intersection, a point of contact between first and second premolars. Now the maxillary molars, this is basically taken for the first and the second molars. Normally in full mouth radiographs, the third molar is not included, primarily because of its most obvious absence in most of the people. So what we take into consideration is the first and the second molars, and this projection is taken for that. Again, the central ray perpendicular to the film and also right angle to the buccal surfaces. So we have to, if we take the curve of the maxillary arch, we have to take into consideration the first and the second molars, then pass a tangent which goes along the buccal surfaces of the first and the second molars. Now this particular plane has to be perpendicular to your central ray. That would be your initial most important consideration while taking an IOPA for maxillary molars. Now the point of entry is nothing but the cheek, which is below the outer canthus of the eye and slightly above the zygoma. So the basic point of consideration would be the outer canthus, and if we drop a perpendicular down from the outer canthus over to the occlusal plane of the maxillary arch, it would meet at a specific point, and that particular point would be your entry point for your central X-ray beam. Now the mandibular, if you go over to the mandibular areas, the central laterals. Now so owing to the small mesodistal dimensions of the mandibular centrals and the laterals, both the laterals as well as the centrals are taken into a single IOP picture, so as to all the four teeth are can be seen on a single radiographic X-ray film. So the central ray, again, it has to pass through the contact spaces between the central and the lateral incisors. That would be a primary aim of the central ray, and the point of entry is obviously below the lower lip, 1 centimeter lateral to the midline. So that is to say, both the central as well as the lateral, since we are taking both of them on a single IOP picture, the entry ray, the central X-ray beam entry won't be same as the maxillary centrals, which is directly through the midline below the septum. This would be slightly away from the midline, so as to accompany both the lateral as well as the central and accommodate into a single IOP picture. So that would be 1 centimeter lateral to the midline and below the lower lip. Now we can see the placements, the patient position, which is slightly more reclined when compared to the maxillary arch images, and this would be placement for the central and the lateral mandibular incisors. Now similarly for the mandibular canine, again, because of the unique positioning of the canine, we have to again take into consideration only the mesial contact opening of the image. So the central ray, which has to take care of the mesial contact, will be directed at the mesial contact point of the canine. Now the point of entry, again, it is perpendicular to the ala of the nose over the position of the canine and 3 centimeters above the inferior border of the mandible. If you see of the picture over here, which is, if you drop a perpendicular from the ala of the nose, now this perpendicular will hit the lower inferior border of the mandible. Now along this line, if we pick out a spot at 3 centimeters above the inferior border of the mandible, it will be directly over the position of the canine, which will give the images specific image of the mandibular canine opening the mesial contact. Now similarly for the mandibular premolar, it is taken for both the first and the second premolars. Now the central ray has to pass through the interproximal contact areas between the premolar molar areas. That is to say, the contact point between the second premolar and the first molar. Now this interproximal contact area has to be taken into consideration while taking a mandibular premolar projection, primarily again to accommodate the lesser mesodistal dimensions of the premolars when compared to the molars. So in this particular projection, we take the contact point between the second premolar and the first molar, and then point a central X-ray beam through the in that specific X-ray image. Now the point of entry, we have to drop a perpendicular from the pupil of the eye, asking the patient to stare straight, and then we take a perpendicular and drop it down from the pupil of the eye, and this again hits the inferior border of the mandible. Now the 3 centimeters above the inferior border of the mandible, that would be your entry point extraorally for your central X-ray beam. Now the mandibular molar, just like in the maxillary molars, we take the first and the second molars into consideration. Then when we take the buccal surfaces and the tangent which passes through these buccal surfaces of the first and the second molars, and the second central ray is positioned through the second molar with a slightly positive angulation. Now we all know the curve of Monson, which actually positions the maxillary mandibular molars and the maxillary molars along the arch of a circle. If we take a circle and pass through it, we see it is a slight, the placement of these mandibular arch is along an arc of a circle. So to compensate for that particular arc, which is placed along the arc of the circle, a slight positive angulation of 8 degrees is given, so that this particular X-ray beam hits at right angles. Now if we give it at a 0 degree angulation, with slight amount of discrepancy in the central X-ray beam as well as the buccal surfaces of the molars, which will give rise to a geometric distortion. To compensate that, a positive angulation is given. Now the point of entry, we have to drop a perpendicular from the outer canthus of the eye and just above the inferior border of mandible. That would be your through the second molar, which would be the external positioning. So that being the paralleling angle techniques for the different specific teeth, the patient positioning, the intraoral X-ray film positioning, the vertical angulations, the horizontal angulations. Now if we in bisecting angle technique, what can be carried over is the patient positioning and the angulations, vertical and the horizontal angulations, which are almost similar between paralleling and bisecting angle technique. The only differences over here is a placement of the X-ray film receptor and the type of cone which we use. Now in this particular technique we use a short cone technique, that is to say the other variant of the cones, the shorter variant of the cone is used for this purpose. And why this is used is based upon the Szymanski's rule of isometry. Now if we take a look at the Szymanski's rule of isometry, it says that two triangles are equal when they share one complete side and have two equal angles. Now what are these two different triangles and two different sides? Now if this is basically the Szymanski's rule, if you take into consideration this particular side which is completely shared by this triangle and the left side triangle, and it has two equal angles over here, then it is to say that the third side will also be equal. Now how this is translated into bisecting angle technique? Now if we take into consideration placement of a central X-ray central incisor and the film receptor. Now the film receptors, unlike in paralleling techniques, it is placed closed or in contact with the lingual surfaces of the teeth in interest. Now if we consider this particular line as a receptor or the X-ray film receptor, which is placed at close proximity in contact with the lingual surfaces of the central incisors. Now the line passing through the long axis of this particular film receptor would be one side of a triangle, and the line passing through the long axis of the central incisors would be the one side of the second triangle. Now the bisector which passes, the imaginary bisector which equally divides this particular angle between the receptor and the teeth, that is a bisector would divide this particular space into two halves or two different triangles, with the sides one being the long axis of the teeth and one being the receptor long axis. Now the central X-ray beams which we position which we project upon this particular area will travel perpendicularly, and the base of these two triangles is formed by the central X-ray beam. Now if we take into consideration geometrically, the base of this two triangles is formed by the central X-ray beams. The middle imaginary bisector is the common side which is shared by this triangle formed by the receptor, and also the triangle which is formed by the long axis of the tooth. So herein what we can see is applying Szymanski's rule of isometry. This is a common side which is shared by the two triangles. This bisector divides this angle into two equal halves, so as to say we have two equal angles. So according to rule of Szymanski's, when two triangles share a common side and have two equal angles, the third side, that is your long axis of the teeth and the receptor image, will be equal. That means to say there is a perfect translation of the lengths or the geometries, the mesodistal dimensions as well as the superior inferior dimensions along the side of this triangle. There is a perfect translation of that particular image, or the shadow is transferred onto the image which holds another side of the triangle. So what we are basically trying to do over here is, even though the receptor and the tooth are not parallel to each other, even though the X-ray beams are not hitting both the surfaces at right angles or not perpendicular to the sagittal planes, so the long axis of these particular images, because of the rule of Szymanski's, because they share equal angles and they share a common side, there will be near replica or exact transformation of the dimensions of the tooth onto the X-ray film. So that what it enables us is, it does not give any distortion in the geometric proportions. There's increased sharpness of the image, primarily because we are reducing the distance between the area of interest as well as the X-ray receptors. Now we all know, as the distance increases, the X-ray beams slightly start to diverge after a specific point of time. So after the X-ray beams hit this particular area, in paralleling technique, what happens is, even though it is parallel, because of the distance between the receptor and the X-ray and the area of interest, there is slight divergence of these rays, thereby reducing a slight bit of amount of sharpness. Now that is totally negated in this particular area, in this particular projection, because we are totally reducing the distance between the receptor and the area of interest, because they are almost in contact with each other. So the sharpness is much more higher when compared to a paralleling angle technique. And even though the distance, even though the areas, the X-ray beams are not parallel to both the surfaces, there is much more higher geometric representation or exact replicas of the tooth in interest. Those are the primary additional advantages of a bisecting angle technique over a paralleling angle technique, along a few other advantages also. Now if you see the vertical angulations, those are the only variances between a paralleling and a bisecting angle technique, and the horizontal angulations remain at 0 degrees for whatever kind of projection we take in. So the incisors, the maxillary and the mandible, because of the maxillary placement of the arch, we give a positive angulation, a positive vertical angulation, and for a mandible we give a negative vertical angulation. The incisors plus 40 gradually increases to canines, because they are the corner points of your arch. The bends or the angulation of the canines is much more when compared to other teeth in its arch. So we give a higher amount of angulation, vertical angulation for the canines. Then we gradually go on to the premolars plus 30, and molars, which has the least amount of angulations within the arch, that is a plus 20. Now similarly for the mandible, just reversal of the angulations, we give a negative vertical angulation starting at minus 15 for incisors. Canines is increased because of the greater angulations, minus 20. Then the premolars minus 10 and molars minus 5. So what are the advantages of a paralleling technique? We have a geometrically accurate image, as I said, because of the paralleling nature of the X-ray beams. Now because of the parallel nature of these X-ray beams, when we take the maxillary molar projections, normally the zygomatic bone shadow overlaps the apices of the molar teeth in a bisecting angle technique, because they are placed in close proximity. But since in paralleling angle technique we increase the distance, the space between the zygomatic bone shadow and the apices of the molar bones is clearly differentiated, and we clearly can make out the difference between the distance between the zygomatic bone and the molars. So that is another advantage of a paralleling angle technique. Now the accurate periodontal bone levels and detection of proximal caries. Both these advantages primarily owing to the fact of the paralleling nature of the X-ray beams, which go at perpendicular angles, hit the alveolar bones at perpendicular angles. So it gives an accurate picture of the levels of the alveolar bones, and also can detect the proximal caries, again because of this advantage. The disadvantages, one is positioning of the film is very difficult, because we have to further distance away from the X-ray receptor from the area of interest. We have to place it deep into the vault of the maxillary arch or the mandibular arch. So that the positioning would be much more difficult. Sometimes because of variations in the anatomy within the arches, the presence of maxillary torus or mandibular torus or shallow palatal vaults, or the placement of because of the presence of the tongue when we are taking mandibular projections. So the placement or the anatomical structures will pose a certain amount of difficulty while placing these X-ray films in an paralleling technique. Now similarly, the difficulty again arises when we are taking the third molar projections. Again, the placement would be much more difficult and impractical, and then the usage of these holders for placing the X-ray films, those have to be autoclaved at a regular basis. Now the advantages are nothing but the reversal of the disadvantages. It is quick and easy, much more easier and much more quick than a paralleling angle technique, primarily because we don't have to use any holders, and primarily we don't have to place the X-ray receptor further away from the tooth. We can easily place it at the lingual surfaces and immediately shoot for an X-ray image. No sterilization of holders, primarily because we don't use any holders, and the positioning of the film is much more easier than the paralleling angle technique, to the reasons which I explained. Now what are the disadvantages? Any difference now, as long as we follow the Szysinski's rule of isometry and we follow geometry and we exactly replicate it in while taking an X-ray image, we won't have any kind of geometric distortion or blurring. But in most of the cases, if there's a slight deviation from this practical usage of the rule of isometry, we'll have foreshortening or elongation on a dramatic basis, and also owing to the fact we also have blurring of the image. Now the periodontal bone levels are not very well represented over here, primarily because the X-ray beams are not parallel to the alveolar bone or the surrounding bone structures. Now the rule of isometry enables us to exactly replicate the size of the teeth, but what happens is the periodontal bone levels, which cannot be accurately represented onto the image because the X-ray beams hit it at an angulation. Now this is not a problem when we come over to the paralleling angle technique. Now to overcome this, we have come up with the bite-wing projections, which I'll be talking about. Now because of this non-parallelism of the X-ray beams to both the receptor and the tooth, we also have the zygomatic bone shadow which falls over to the apices of the maxillary teeth. And also because of that, because of the non-parallelism, we also are not able to make out any proximal caries present, again because of the non-parallelism of the X-ray beams. So we talked about the disadvantages of the bisecting angle technique. By and large, bisecting angle technique is the most common technique which we use in a dental setup by the dental physicians. So to overcome these disadvantages, the primarily non-detection of the proximal caries, non-detection of the secondary caries below a restorative material, to estimate the periodontal levels, bone levels, accurate measurements of these periodontal bone levels for a periodontal to determine the periodontal health of that particular tooth. So to detect any calculus or caries within the interproximal areas, which have to have parallel X-ray beams hitting it so as to obtain the accurate information, which these are disadvantages of using a bisecting angle technique. And specifically to overcome these disadvantages, we have come up with a bite-wing examination, wherein the basic indications of bite-wing examinations are to overcome all the disadvantages of a bisecting angle technique. So this is basically an interproximal examination which includes the crowns of both the maxillary and the mandibular teeth and the alveolar crest of the same film. Now since because of the unique angulation which we give in a bite-wing examination, we won't be able to bring out any information of the periapexis. This image limits itself to the crown portions of the maxillary and the mandibular teeth, and primarily the most important use are to determine the periodontal bone levels and the health and presence of any abnormal structures within this specific area. This is a placement of the bite-wing image, the X-ray film which we use is similar to intraoral periapical radiographs. The only difference is we use the paper tab, which is around about roughly at the midline of the X-ray film, upon which the patient bites, so that both the crowns of the maxillary and the mandibular are accommodated on a single image. Now the different sizes depending upon where we are using and whom we are using and what kind of teeth are we using. We have size 0, which is used for posterior teeth of the children, size 1 which we use for posterior teeth of mixed dentition as well as anterior teeth for adults. We have size 2 which is used for posterior teeth for adults, and which there is a slight modification of the size 2 which is a size 3, wherein both the premolars as well as the molars are accommodated in a single image, wherein to say this particular radiograph is much more longer when compared to a size 2. Now the basic angulations which we follow in a bite-wing examination varies from +5 to +8, primarily to compensate the curve of monsoon, and this enables the X-ray beams to hit perpendicularly to the periodontal bone or the supporting bone. Now this is the holder which we use, which is similar to somewhat similar to the Palingong angle technique holders. The only difference, we have a bite tab over here upon which the patient bites onto the tab, and both the crowns of maxillary and mandibular are captured over a single image. Now the basically two types of bite-wing projections. The first one is the premolar bite-wing projection, that is the central ray which has to pass through the center of the film, because both the maxillary and the mandibular teeth have to be accommodated through the second premolar and the molar contact area. Now this again owing to the mesodistal dimensions of the premolars, the central ray has to pass through the contact point between the second premolar and the first molar, and a vertical angulation of +5 which compensates the curve of monsoon. The placement is, as you can see over here, our patient is asked to bite onto the bite tab. The film is placed so as to accommodate both the crowns and the of the maxillary as well as the mandibular arches, and the placement of the cone at a slight positive angulation. Similarly, for a molar bite-wing, this passes through the contact point of the first and the second molars. Now it enters the cheek below the lateral canthus of the eye. Now the vertical angulation, because of the much more greater angulations of the curve of monsoon, we give +8 to +10 degrees positive angulations. The same placement of the cone and the positioning of the patient. The only difference, the central ray passes through the perpendicular which is dropped from the lateral canthus of the eye, and which meets the occlusal plane. Now this is a sample picture of the molar bite wings. You can easily see the crowns of the mandibular and the maxillary teeth, as well as the interproximal bone. Now, so what are the advantages? It basically translates all the disadvantages of bisectic angle technique into advantages. So it is simple, very inexpensive, no usage of any extra holders. It is just a simple paper tab which is used, and because of its simplicity of usage, it can be easily used in children also. Now, what are the disadvantages? As we have seen in the placement of the X-ray films, we see that it is much more arbitrary. That is to say, it cannot be reproduced to the similar extent if we use it at two different times in two different people at two different times. So what's happening over here is we don't have a specific cone positioning image or indicators which can position the cone at the same position at two different times. It is an arbitrary subjective dental physician specific image which we are producing over here. We have the paper tabs which we use inside the mouth. Now that do not have any external indicators as to where we have to point the cones to produce that image. So the risk of cone cut, that is improper or impartial projection of the image onto the X-ray film, is much more greater in a bite-wing examination, Now it is arbitrary because we don't have a cone indicators or placements. It totally depends upon the dental physician. Now again, the stability of the film because of the tongue, which is in continuous contact with the lingual surfaces, also have to be taken care. Now that being the disadvantages. So now we move over to the third type of intraoral radiographies, which are most commonly used, that is the occlusal radiographies. Now basically what we use or do over here is to enable the dental physician to take out information from the whole arch of either the maxillary or the mandibular arches and the surrounding structures. So these are basically intraoral radiographic films, which are much more larger in size than the other kinds of radiographic techniques which we have talked about, and wherein the film packet is placed along the occlusal plane so as to take out information from the whole plane and its surrounding structures. Now because of its vast coverage and its better details, the indications or the usage of occlusal radiographs is far more greater than either bite-wing or intraoral periapical radiographs. All the teeth in its arch, the surrounding structures, be it the floor of the mouth or be it the bony structures or the soft structures, the palate, the maxillary sinus, the nasal septum or the nasal fossas, all the surrounding bony structures surrounding the maxillary arch or the mandibular arch are totally seen by using an occlusal radiograph. Now, other most important use of occlusal radiographs is in its 3D localization. Now, if we, as I'll talk about it later, the angulations of this occlusal radiographs is much more steeper. Now, we all know that is basically these radiographs which we are taking is a representation of a 3D structure over a 2-dimensional radiographic film. So, to determine the third dimension of this particular of the oral structures, a combination of occlusal radiographs with periapical or bite-wing radiographs is used so as to bring out the 3D representations of of the intraoral cavities to determine the placement of a specific anomaly or a specific tooth in a 3-dimensional structure. So to obtaining information from both the occlusal as well as the intraoral periapical radiographs, we can exactly localize or locate a specific tooth in a 3-dimensional way. Now, depending upon the areas of the occlusal arch which are taken into consideration or which are studied, and depending upon the arch which we are taking into consideration, we can broadly classify them into maxillary occlusal and mandibular occlusal projections, among which we have the standard occlusal, oblique occlusal as well as vertex occlusal. Obviously, vertex occlusal not anymore used right now. In mandibular, we have this the true occlusal or the lower 90-degree occlusal or the lower 45-degree occlusal or the lower oblique occlusal. So, what are these angulations? Coming over to the anterior maxillary occlusal projection, it is basically to determine the anterior occlusal area or the anterior teeth and its surrounding structures of the maxillary area. So, what we see over here is teeth ranging from the canine to the canine of the maxillary arch and its surrounding structures as like the nasal septum, the anterior palate or the nasal fossae. So, all the anterior bony structures and the anterior teeth are taken into consideration over here, and then the image is taken. Now, the patient positioning over here is similar to intraoral periapical radiographs which we take. The only difference is the larger radiographic films which we use over here. Now these occlusal radiographic films is basically about 27 into 54 millimeters, the standard size of an occlusal radiograph. And how we place it for an anterior maxillary occlusal, it is basically a rectangular shaped radiographic film. So the long axis of the longer side of the occlusal film is placed perpendicular to the sagittal plane along the occlusal plane of the anterior of the maxillary arch, and it is placed in this positioning and pushed into the patient's mouth until the posterior end of this occlusal film hits the rami of the mandible. So until there it is pushed inside, and then to stabilize this occlusal radiograph within the occlusal arch, the patient is asked to slightly bite onto the occlusal film, or the operator might use both his thumbs to stabilize it against the occlusal arch. So that would be the positioning of the radiographic film inside the patient's oral cavity, and the positioning of the X-ray cone. The X-ray beam is placed at a steep angulation, which passes, the central X-ray beam passes through the tip of the nose at a 45 degrees angulation, and obviously 0 degrees horizontal angulation. So that enables us to view the anterior teeth and its structures from up-down position, and this also helps in conjunction with the intraoral radiograph to give a third dimension to these 3D structures. Now we can see the patient positioning just like in a maxillary intraoral periapical positioning. The patient is asked to sit upright. The film position, as I told, is placed, and then the X-ray beam is passed at 45 degrees through the tip of the nose. Now the cross-sectional maxillary occlusal, the basic difference is we are taking a total cross-section of the entire maxillary arch. It is not only the anterior maxillary arch which is taken into consideration. The entire arch is taken into consideration. So to bring out the information of the entire arch, obviously we have to increase the angulation to much more steeper angles from much more up-down position. That is basically what we are doing over here. The central ray is passed through the bridge of the nose instead of the tip of the nose. So we are taking it higher up, and we are increasing the angulation from 45 degrees to 60 degrees so as to cover the entire maxillary arch and give a cross section of the entire maxillary arch. So the resultant picture, what we see is basically the occlusal tables of the teeth in the maxillary arch, and only the root tips of the anterior teeth in the maxillary arch. The placement of the position of the patient similar to the previous image, but the placement of the cone slightly more steeper and higher up. Now this lateral maxillary occlusal. Now we are, as the name suggests, what we take into consideration over here is only one half or one side of the maxillary arch. One lateral part of the maxillary arch is taken into consideration. So we take the incisors to the molars of only one arch, or one side of the arch is taken into consideration over here. Now the central ray is placed 2 centimeters below the lateral canthus of the eye, directed to the central of the film, with a similar angulation as in cross-sectional maxillary of plus 60. So what we do over here is now the placement of the film is different from the previous two images. Now the long axis of the occlusal film is placed parallel to the sagittal plane in this condition, pushed inside the patient's mouth. The posterior end hits the rami of the mandible, then it is shifted to one side of the area of interest, either the right or the left, and it is pushed to such an extent that the buccal surfaces of the molars and the premolars will the X-ray film pushes 1 centimeter beyond the buccal surfaces of the molars or the premolars, so as to adequately cover all the specific teeth in that particular arch, and then it is stopped over there. Now then the patient is made to bite onto the film slightly, and then the positioning of the cone is as such that it entirely focuses on the bony structures surrounding that specific area. So it perpendicular is dropped from the lateral canthus of the eye 2 centimeters below, and it is positioned directed towards the center of the film. Now this being the position of the patient and the cone for a lateral maxillary occlusal projection. Now coming over to the mandibular, similarly like an anterior maxillary occlusal projection, we have an anterior mandibular occlusal projection. Again, the area of interest over here are only the anterior teeth, the canine to canine, and the bony structures and the floor of the mouth surrounding this particular area. Now again the patient position, just like in intraoral examinations, the patient is reclined back at 45 degrees. Now the tip of the chin is taken into consideration over here, and that is where the X-ray beam is positioned extraorally with a minus 10 degrees. So along with the 45 degrees angulation which is attributed to the patient position, and the minus 10 degrees angulation which is attributed to the cone of the beam, a total angulation of minus 55 degrees is obtained over here. So that enables us to see the anterior teeth of the mandibular arch and its surrounding structures. This is the positioning of the patient as well as the cone. Now similarly, we have the cross-sectional variant of the mandibular occlusal, wherein we take a total cross-sectional plane of the entire mandibular arch, just like in maxillary projections, and then we see the occlusal tables of the teeth present over here and the surrounding structures, the lingual cortical plates, the buccal cortical plates. So basically any anomaly or cysts or tumors or supernumerary teeth in the third dimension, that is a mesodistal dimension, can be easily seen by these projections. So any fractures in the mesodistal line or any supraerupted supernumerary teeth or impacted teeth, all in the mesodistal dimensions, or any expansions of the lingual or the buccal cortical plates because of cysts or tumors or inflammatory diseases, all this can be easily seen by these projections. So here, because the projection is through the floor of the mouth, hardly any bony structures over there, it is all soft tissue, so thereby the exposure time is reduced to 1/2 of the normal exposure time, and the central ray is basically passes to the midline through the floor of the mouth 3 centimeters below the chin and 90 degrees obviously to the film, because it is a cross-sectional projection. This 3 centimeters below the chin, basically it points out this central X-ray towards the center of the film. The positioning of the film again is similar to maxillary, wherein the long axis of the occlusal film is perpendicular to the sagittal plane, pushed inside, touches the rami of the mandible, and the patient is asked to stabilize it by gently biting onto the film. Now similar like lateral maxillary occlusal, we have a lateral mandibular occlusal projection, wherein we have to take into consideration either only the right side or the left side of the lateral halves of the mandibular arch. Now the patient film positioning is slightly different. The long axis of the film is now parallel to the sagittal plane, pushed inside and moved to one side of the specific area of interest. Again, it is extended so that only 1 centimeter of the edge of the film goes past the buccal surfaces of the premolars or the molars, and then a patient is asked to stabilize. The placement of the cone is 3 centimeters below the tip of the chin, and again 3 centimeters away from the midline of the floor of the mouth. That enables us to entirely visualize 1/2 or the lateral half of the mandibular arch. So these being the normal radiographic techniques which we normally use in our dental setup. Now how to determine or differentiate normal structures, normal radiographic structures, be it the radio-opaque structures or the radiolucent structures, from the abnormal structures. So that we have to know only after having a thorough knowledge of the normal anatomical landmarks seen on these radiographs. So in the maxillary, if we divide them into radio-opaque and radiolucent, we can see starting from the nasal septum along the midline, going laterally to the floor of the nasal cavity, the floor of the antrum, going up to the hamelar process and the tuberosities. All these are bony structures or radio-opaque structures seen in the maxilla. Now the radiolucent structures we have again from the midline, the nasolabial fold, the nose itself, starting the maxillary sinus, going up to the superior foramina of the nasopalatine canal, up to the inferior mandibular canal, which are all the radiolucent structures seen in the maxilla. The mandibular, on the other hand, again the radio-opaque and radiolucent structures, the radio-opaque structures starting from the midline, we have the genial tubercles starting going backwards. We have the mental ridge, the external oblique ridge, the inferior cortical border, and the coronary process. All these starting from the midline up to extending backwards. Then we have the radiolucent structures. We have the lingual foramen, which is the midline structure. Going backwards, we have the mental fossa, digastric fossa, start up to the end of this particular radiolucent spectrum. We have the submandibular fossa. I'll be showing this normal anatomical landmarks in these. We can see over here the nasal septum. There is a maxillary projection. We have the nasal septum, which is a radio-opaque midline structure. We have the soft, if we see this structure over here, we can see a slight radio-opaque borders extending from the left to the right side. This is nothing but the soft tissue shadow of the nose. We have the anterior nasal spine, the tip of the radio-opaque structure. Again, this is the midline radio-opaque. We have the floor of the nasal cavity, we can see over here, and the nasal septum, which I told is a radio-opaque structure seen in the midline. The radiolucent structures, we can see the inferior nasal concas, the nasal septums or the nasal fossae. We have the incisal foramen, which is a slight radio-opaque oval-shaped radiolucent structure seen between the middle thirds of the roots of the central incisors. Over here, we can easily translate it over here and see the oval structure seen over. Similarly, we have the lateral fossa, just like the incisal fossa, present between the adjacent to the roots of the middle third of the lateral incisor, as we can see over here. We have the floor of the nasal antrum, that is the maxillary sinus, the floor designated by the radio-opaque line, and the radiolucent structure. Now, how we can differentiate this maxillary sinus from any other sinuses or cysts which might be seen in connection with this particular molar or the premolars? The basic difference would be the presence of neurovascular bundles, which can be seen as well-defined radiolucent structures within the space or the antrum of the maxillary sinus. Now, as you can see over here, we can easily distinguish two parallel lines, which are radiolucent lines traversing longitudinally in the maxillary sinus, which are nothing but the neurovascular bundles within the maxillary sinus. Now that gives us an indication that this is a normal radiolucent structure and not a radiolucency which may be attributed to any cysts or tumors associated with this tooth over here. Now, as we go posterior, we can see the zygomatic process. Now, we can easily know that this is a paling angle technique radiograph, primarily because the zygomatic process is not overlapping over the apices of the maxillary teeth. That would not be the case if we had taken a bisecting angle technique, wherein this zygomatic process will easily overlap over the apices of the maxillary teeth. Now, if you go even more posterior, we see the radio-opaque hamular process, which is a well-defined triangular or rectangular radio-opaque process posterior to the maxillary teeth, and then we have the end, which is the maxillary tuberosity. Now, moving on to the mandibular areas, we have the mental foramen, primarily seen as a radiolucent area between the roots of the premolars, first and the second premolars. We have the mandibular canal, which is a radiolucent structure passing at the inferior, just above the inferior border of the mandible, surrounded by a hard cortical borders of the canals, which is seen as a radio-opaque structure. Now, that in total constitutes the mandibular canal. The mental foramen and the mandibular canal more distinguished, and the surrounding cortical plates of the mandibular canal. We can also see the lower border of the mandible, which is the lower extent of the mandible, seen as a radio-opaque ending. If you go posterior to the maxillary areas, we can see the coronoid process. Now, this coronoid process is seen as a faint radio-opaque shadow, primarily when the patient is widely opening his mouth. In a closed mouth condition, we do not see this coronoid process because it does not translate forward. But in an open position, because the coronoid process translates forward, we can see the faint radio-opaque structure at the posterior or the distal end of this radiographic image. Then we see the midline radiolucent structure, that is a lingual foramen. It is basically a ring-shaped structure with a central radiolucent area surrounded by a radio-opaque band. That would be the lingual foramen in the mandibular structure. Now we can see the mental ridge. We can see again the ring-like structure of the lingual foramen, the nutrient canals, and the mental ridge, which is a radio-opaque line crossing the apices of the anterior teeth. Now we see posteriorly we have the external oblique ridge, which is a radio-opaque image starting from the ramus of the mandible, continuing forward and downward along the lower border of the mandible or the ramus of the mandible. Then we see inferior to that radio-opaque structure another radio-opaque well-defined line, that is a mylohyoid ridge. Now we have the fossae, the radiolucent structures. In the midline we have the mental fossae. In the posteriorly we have the submandibular gland fossae, the resting the place of lodgement of the submandibular salivary glands. Now we have the mental foramen again, which is a radiolucent structure along with the mandibular canal. So that brings us to the end of the intraoral radiographic techniques which are commonly used in a dental setup, and how we can differentiate the normal anatomical landmarks from the abnormal by seeing the normal radiopaque and radiolucent structures of both the maxillary and mandibular. Thank you.